Everyone, welcome. We're very excited to see everyone here for our very first NPC Lunch and Learn. So it's just going to be a true, honest live Q&A. We really wanted to have this open forum for medical providers in the functional field, wellness integrative, to come and really lay out any questions, protocols, just anything to do with this field, just to help, even from getting started to more advanced cases. Um, Please feel free to unmute yourself if you have questions. Video on or off, it's completely up to you. If you don't feel comfortable asking in out loud, please feel free to put it in the chat. We'll monitor that. But we did have questions sent in. So Brent, I'm just gonna read. I'm gonna just to start us off, and then please feel
Yeah,
free. You can read. Yeah.
yeah, let me just say one thing real quick. And so just remember that these questions that you guys are asking can be business related as well. I know a lot of people that get into functional medicine have their foot kind of halfway through the door. Some people have dual strategies where they're still taking insurance on one side, they're doing cash on the other. If you're just trying to find ways to improve your business in a whole as a whole, just talking to patients, how do you approach therapies with patients, anything that you guys have to think that you can think about that would improve the scenario you're in, or a barrier that you've kind of hit. Just feel free to ask that because this is for the people that don't know me, this is all I've done my whole career. I've never practiced in a traditional practice. This is functional medicine is where I've lived, concierge medicine since 2002. So I have probably come up against any of these obstacles you guys might be facing, both clinically and business. So if you have questions, please fire them. This is an opportunity for hopefully people to get some of these questions that have been holding them from furthering or advancing their clinics. But yes, Casey, you can go ahead and fire any questions you have.
Okay, so the first one that was submitted. So I am interested in more information on bioregulators, how they work to support peptides. I'm really looking for in-depth education on the value of bioregulators, and what systems they support in the body. And then there's a follow-up question she sent, but I'm going to go with that one first.
Okay, so she said the difference between bioregulators and peptides, or how bioregulators can support peptides.
So yeah, more information on bioregulators, how they work to support peptides, and just like what systems they really affect in the body.
Okay. So so in some of our talks, you'll hear us kind of talking about the peptide world and all the different peptides out there. And so when people are talking about bioregulators versus just peptide therapies, for the most part, they're talking about the kind of a global approach to wellness or longevity. And so the bioregulators are ones that don't usually work on one receptor site or cause one specific action. A great example is a growth hormone secretagogue. So when you're looking at some of the main bioregulators we talk about are going to be something that affects a great one is epitalon, which affects telomerase or telomeres. MOTS-c, again, or any of the mitochondrial peptides. And the idea is that the bioregulators are used more of for longevity instead of trying to execute a specific response in the body. And so, to me, we talked about, when people always ask, well, how do we approach peptides? Do we cycle them? Which ones should we be on long term? Which ones do we go on for specific time periods? And you're going to see that the bioregulators are ones that you fit into a regimen over time. These are also some of the peptides that aren't going to create that wow situation where you go on one of these peptides and it increases sexual function or it increases growth hormone stimulation, which leads to weight loss and to improved overall vitality. These are ones that are kind of going on in the background, supporting all of the systems through their methods or their mechanisms of action. And epitalon's a great one because, or any of the mitochondrial peptides, even some of the neuropeptides fall into this category because they're not working on one receptor site, but yet they're globally affecting either the nervous system or multiple systems or DNA repair or something that's going to create an opportunity for improved health, improved wellness, or longevity without working specifically on one specific action in the body. So the way I use these is again is that these are another one on the nutrient side would be glutathione or alpha lipoic acid, something that you take. We know it's a great antioxidant. We know it has a great support in the body. We know our body's needs are reduced as we age, but we still take these because we know what they're doing in the body, even though we can't say, "Oh my gosh, I feel so much better after taking glutathione." That's how I approach the bioregulators is I fit them into a regimen and I tell them to explain them how they work, explain the science behind them, and then place those in a routine throughout the year. Usually epitalons twice a year, MOTS-Cs usually once or twice a year, but you can even stagger those on top of each other. And the consideration is these are products that are going to create a better internal environment overall, improving the way peptides are going to work in the body when you take them. So that's kind of the way you look at it is those bioregulators are something that we're looking for lifestyle to create. It's almost the same way we talk about how you don't want to go on a peptide if you're not doing the other factors of lifestyle because you're only going to get a partial response. This is the same way. If you're using bioregulators, you put them on periodically, and when they're on these bioregulators, surrounded with good lifestyle, they're going to make the peptide therapies and the nutrient therapies work that much better, if that makes sense. So you want to use those in conjunction, but remember they work very differently, and the bioregulators are the silent producers of results that we just have to use the science on that we're not going to see a tangible response physically that some of the peptides provide.
So then she had a second question. Doesn't quite go with it, but she wanted to know what is a maintenance dosage of a GLP-1 such as tirzepatide and how to best frame the benefits of maintenance usage with clients. I do want to follow up that someone else sent in a question asking at what point do you recommend transitioning off GLP? So I don't know if you want to talk about maintenance versus transitioning off and
So I'm going to let Kathy talk about the maintenance dosing. Kathy, are you there?
Yes.
Yeah,
So,
do you want to talk about the maintenance dosing, and then I'll talk about the duration of the treatment.
so the maintenance dosing is going to vary for every client. I always tell people, use the least amount of medication that you need. And for everybody, that's going to vary. For some people, it's going to be the starting dose. Other people, unfortunately, if they have difficulty with food noise, cravings, then that's going to be on the higher end of the recommended dosage. So everybody is very, very different, and each person has to find that sweet spot that works for them.
Is there a kind of would you say a standard dosing for both semaglutide and tirzepatide that's your maintenance dose that you like?
I mean, I like to have the lowest dose possible. So if I could get everybody down to the starting dose, that's what I would, taper them down to the starting dose and have that as their maintenance. But for the vast majority of people who continually increase it to the max dose, they're the ones that are going to have the most difficult time with a low dose. But people that microdose and increase it very, very slowly and never get to that maximum dose, those are the ones that can usually stay with like tirzepatide, stay at around 2.5, maybe 5 milligrams at the most. But the people that keep going up and up to 12 and a half, 15 milligrams, they're the ones that have the hardest, finding a good maintenance dose of much below 10 or 12 milligrams.
What percentage of people do you have under the starting dose as a maintenance? So like a half of the starting dose on tirzepatide or semaglutide.
Semaglutide, none. Tirzepatide, there are quite a few people, but those are the people that only had maybe 10 or 15 pounds to lose. Those that are using it primarily for inflammation reduction, then they're using maybe 1.25 milligrams.
Okay.
But the vast majority of people are very obese that are using these, and they're just increasing to the maximum amount. They don't always have the lifestyle in there like they should. and therefore trying to reduce them much below 10 milligrams becomes difficult. So I would say maybe 35, 40% that are able to keep it at 5 milligrams or less of tirzepatide.
Okay. Okay, and so that's good information. Thank you, Kathy. And then the rest of that question was is what is the long-term outlook look on GLP-1s? How long do we recommend people being on GLP-1s? And as Kathy said, that's going to be very individual as well. But when we look at the data, which there is not much of, so remember there is no long-term data on GLP-1 uses, especially for just obesity. You know, they're talking about longevity, but again, there's no 5 to 10 years worth of data. So we have to consider that right now, our responsibility as physicians is to provide the best path forward for people to reach health and happiness, you know, for longevity, for wellness. And when we don't know long-term data, that means to me that this is a strategy. This no different than putting someone on you know, phentermine or phendimetrazine that are really struggling with appetite at the beginning of a weight management program. You put them on it, we do it, we've used them. There's nothing better for helping someone along when they're really struggling but very motivated. So using these GLP-1s has a position where that we haven't had this type of solution before, that works so solidly for that first stage of weight management. So if you look at it that way, you're going to want to use these drugs, but at the same time, if you're really pushing functional medicine, so that meaning that's a functional use of this GLP-1 peptide, that means you're also educating. Because remember, the peptide can silence the noise, but that leaves us responsible for doing the education. You know, if they don't know what they need to learn and achieve while taking this GLP-1, meaning macronutrient, micronutrient management, exercise, sleep, things that normally would trigger us to eat and be responsible for the type amount of foods we bring in. When you have something that's numbing that noise and numbing that communication, you have to be the one to educate the clients that they have to be on top of their micronutrient, macronutrient, or caloric intake. And so I would say the individual, it really comes down to working with each one. As soon as someone's starting to get towards their goal weight, you have to start having that conversation about food. What's your relationship? How many calories you're getting in a day? And if these people don't know those answers, that means that they're really heavily relying on the drug and they're not ready to come off of it yet.
Right.
And so again, this is our job as educators in giving them the best responses to say, okay, well, we need to start knowing that information. Get them on MyFitnessPal. Start figuring out how many days they're exercising. You have to have this information so that you can properly guide them when to get off of it. Now, we have patients that have been on them for over a year. We have patients that have had to lose 100, 200 pounds. But we also have the ones that are, you know, just need to lose 20 or 30 pounds. And those people we're going to want to get on the GLP-1s, have them figure out where they were lacking in their lifestyle, correct those lifestyle deficits, and then start to taper off the GLP-1s. And at that time, you can use some of the other repertoire tools in the toolbox to support that GLP-1 taper, like we've talked about, NED, methylene blue, berberine, some of the GH growth hormone secretagogues. These are all things that can kind of keep the metabolism at a higher rate as they're trying to slowly taper off of the GLP-1s. And Kathy, do you have a specific tapering regimen that you have? Is it, you know, how much per week that you're trying to drop?
So I usually tell people, like for tirzepatide, to drop it, basically to go the opposite direction. So you start at 2.5 milligrams, you start weaning down, so you could do 4 weeks. If you're at 12.5, come down to 10 milligrams for 4 weeks. So I usually tell people to come down off of it very, very, very slowly.
Nice.
And with tirzepatide, sometimes I have them go even slower just by dropping it like 5 units at a time. So just very, very small amounts. But yeah, I mean, people have to do it very, very slowly. And it's usually over several months.
Yeah, so understanding that tapering part of it, you can already see that if it has to be several months of tapering, you can see that a year is, even some of the other more outspoken functional medicine doctors out there that are on the internet, some of them say that they think it's a great tool, but they're like me. They're very skeptical on a pharmaceutical company producing something that creates health. I mean, that's not what our healthcare system has been built off of. So, it's so am I wrong to be just waiting for the here's some of the downside of the GLP-1s in the next couple of years. I'm waiting for it because I just expect it because that's how history has repeated itself. So with that concept, it's really basically in your mind is get them on, get them started, get them going, get the results, and start them on their tapering. And that number has been around a year. That's kind of the way a lot of these docs are looking at it is get them on it, get the results, get them started on the tapering side while they're building the lifestyle deficits that they had so that they come out with a better lifestyle regimen and a better chance of not regaining the weight. Because as you guys might know through friends, families, patients, right now, the people that are stopping that are having very similar percentages of weight regain. It's about 20%. 20% of the population that are on GLP-1s are maintaining. Close to 70-80% of the ones that stop the medication start to regain their weight.
Yeah.
So when you know that statistic, you can kind of see that we're in no different situation than any other diet if people aren't understanding what they have to change when they're on the drug. So this is a very sensitive topic and conversation because you have half of the functional medicine world saying, "Oh yeah, this is the longevity drug that we've been waiting for. Stay on it for the rest of your life." And then you have others that are just skeptical because you can't bypass normal metabolism and normal behaviors and normal physiology with a drug and expect that there's not going to be consequences. The body's too smart to not learn what you're doing. And so I always say with caution, so I tell people try to shoot for a year and get people on and off. But obviously, if people have diabetes or severe obesity, that might end up being 2, 3 years. But to think of it as a long-term longevity drug, we just don't have the data to support it.
And then this just goes kind of with this topic. Is there any dosing or stacking suggestions when using sublingual or liquid GLP-1s?
Um, yeah, we don't, that's even newer. This is this is upcoming medicine and not using injectable. I mean, the drug has the same half-life no matter what. So all we're doing is looking at bioavailability and then with the oral drugs, all you're doing is somewhat complicating things in a way because now you have to look at each person you have and you're dealing with. What is their gastrointestinal microbiome situation? What is their how often are they eating meals? How much food are they eating? What's their transit time? Do they have any inflammatory bowel or irritable bowel syndrome? So I think the orals are a great concept, but just like with anything, when you have less than 20% absorption, you're going to be playing around with that dosing and really trying to play around with are people taking it on an empty stomach? What is their internal environment? So I don't see orals passing over injectables. Um, and so when you talk about stacking, again, you're really trying to see how people respond to it. What are their side effect profile? And if they're meaning stacking, are there other drugs that you can stack on top of it? Or are you meaning, are there more than one GLP-1 to stack on top of each other?
This was sent in beforehand, so I don't have clarification on that. I think she's here. I don't know if she wants to unmute to get, I don't know.
Yes. Casey, this is Cindy. Can you
Hi.
hear me?
Yep.
Hey. I was just kind of thinking, do you stack it the same as like the injectables with other things like we do the injectables? Not
Oh,
not on top of another GLP. No.
yeah, absolutely. Yeah, anything that you can do that is going to support the other lifestyle factors, so if you can get someone on and of course you have to be careful because a lot of this stuff is completely related to food intake and micronutrients
Okay.
and so if you can help someone that is trying to do a microdose of a GLP-1 but maximize exercise response, recovery. You can get really, really creative with some of the peptides, especially those that are doing it the right way. If they're tracking their macronutrients and they're on a you want it, yeah, you put them on a B12, put them on a B complex injection, put them on a growth hormone stimulator. These are all things that are going to help them fill in those gaps in their lifestyle, start getting result, hopefully burn off some of this stubborn body fat that they weren't able to get rid of, and then use these changes in their lifestyles and some of these other therapies that you put them on to keep them from needing the GLP-1 long term.
Okay, thank you.
Hmm?
Okay, so I'm going to switch to some questions in the chat. So, how would you treat Guillain-Barré for mental fog?
So Guillain-Barré is a tough one, you know. So any of the neurological modulators, anything that's going to reduce sympathetic tone, you know, any of the anti-inflammatories. Now, I don't know, you know, a lot of the neuropeptides, cerebrolysin, Cmax, cortexin, C-Lank, dihexa, all of these neuropeptides all work on raising brain-derived neurotropic factor, which is a protein that heals the brain. So with Guillain-Barré being a neurological condition, I would say any of those peptides would be helpful. You would just have to look and see if there was any that had specific human or animal studies related to Guillain-Barré. But I would also high dose B12, methylcobalamin injections, glutathione, you know, the BPCs, TB500s. But again, I would also, you know, stress intermittent fasting or periodic fasting. You can never underestimate the power of fasting. So if I had any major neurological condition, any neurodegenerative disease, any condition with the nervous system, I would be doing, you know, 38 or 48, 72-hour water fasts. I would be trying to do aggressive intermittent fasting and then augmenting that with some of these neuropeptides or some of these other micronutrients that I think are very, very directly correlated with some of these inabilities for our immune system to fix the problem. And micronutrients are going to continue to be something that we cannot catch up. You know, it's just we're always in the rears with micronutrients. So B vitamins, and the minerals. You know, that's would be my. And then what was the second half? That was Guillain-Barré, and then what was the other part of it?
The mental fog that comes with that.
Oh, Guillain-Barré. Yeah, so same thing. It's hormones. Now that you know DHEA is a big one. You know that's one that I can tell you that if we get a consistent response and reduction of brain fog, it's those clients of ours, especially women, that
Yes.
go on HRT. You know, and Kathy, do you want to mention anything? Because you do a lot of the follow-ups with the women. I just know in all of our follow-ups that we do, brain fog is usually in 3 months one of those things that has already been resolved with a little HRT.
Yeah, definitely. And I would say that the DHEA is, when it comes to the brain fog, is one of the most valuable.
Yeah, and you know, and that's one that with women and men, you know, that are between the ages of 40 and 60, almost all of them are low in DHEA and pregnenolone. Almost all of them. It's like I would say 90% are low. So even if you took someone that's complaining of brain fog, and even regardless of your lab testing, if you don't have any, you put someone on 5 to 25 milligrams of DHEA, you know, 10 milligrams or 50 to 100 of pregnenolone in the evenings, chances are within a couple weeks they're going to notice improvements in their brain fog.
And then someone else asked, how long is it okay to stay on dihexa?
Yeah, that's a good question as well. So when you're you know we get questions all the time about peptide cycling, and there is nothing. I would, if anyone can find any data on, you know, what is the gold standard for cycling these peptides, there's really rarely any suggestions or any long-term data on what to do with these things. So again, my the easy way to approach functional medicine is, remember, this is function. All we're trying to do is improve function in the body. That is our job. Is if there's a root cause of disease, we want to find that root cause and we want to correct it. If someone doesn't have symptoms, it leaves you you're not trying to find out some sort of a solution that's going to, generate business for your practice. You're trying to figure out what the needs are, or what are the functional needs that person has to maintain. So again, we already know they're never going to catch up in micronutrients. So micronutrients is a big one. But when you're looking at these peptides, again, if someone has brain fog, if they have memory issues, if they have focus problems, you first want to find out what's wrong with their lifestyle. What is going on that we can self-correct through free lifestyle enhancements. And then you want to try dihexa. So if these people are making lifestyle changes, they're complaining of brain fog, memory loss, lack of focus, you put them on the dihexa and you start making lifestyle changes. If they get a response on the dihexa, I usually use the 90-day rule. I use 3 to 6 months is kind of my window, and then I start cycling, and I pretty much cycle everything. And there's no gold standard for that, but you have to think, again, the body is extremely smart. And if you're just feeding it the same thing over and over and over again, even at times when you don't even really need it, because you're thinking, well, hey, my brain fog's gone, I'm just going to keep taking dihexa every single day. That can't be the way you look at it. You got to think about this is that you're going to do a 3 month, 6 month cycle, then you're going to reassess. And in that reassessment, you have to make sure that these peoples have made the lifestyle changes that they needed to, had their hormones checked. Because again, after we get to a certain age, hormones are going to be something they're on continuously. So when you look at how you can manage your business, when you have people, you don't have to keep them on peptides, because chances are they need to be on micronutrients. So this is how your business can keep on. Like, for example, I have tons of patients that I see once a year, and they're on HRT, they're on micronutrients, they're on peptides. We set that program in place. Then for 11 months out of the year, they're just refilling medicines. They're just dealing with the front desk. Everything's going well. They're refilling medicines. The business is making money. But we're not just peppering them with peptides saying, hey, it's working, stay on it. You have to think that you only need these peptides if there's a functional use of them. And a lot of them create the opportunity, fix the lifestyle, then you're not going to need that peptide for a while. So I would say, give 3 to 6 months, then you take them off of it. See how they're doing, seeing if they're making the changes that they need to. And if you get them off of it and everything's great, perfect. If after a couple months they start saying, oh man, I'm starting to get that brain fog back, put them back on the dihexa again. But you have to also think, what are they missing? What is causing this problem that they're having? And then of course, I always go to hormones. That's, hormones are micronutrients. Those are the two things that we just seem to always be in the rears. And so peptides are kind of those products that are just going to augment the treatment plan that you're putting them on. And so you can have a great business model without, always having people on multiple peptides. And so you look at dihexa, I mean, that's one that I've seen work amazing. But again, you don't want to falsely provide brain-derived neurotropic factor and then somehow potentially, again, there's no research, potentially get your brain to start saying, hey, we don't need brain-derived neurotropic factor. We're going to stop making it internally because we have this dihexa nonstop, a year after year, just taking dihexa. So again, without long-term data and a lot of paid-for research that we can pull from, we just have to be smart and realize that the body is very it's malleable. It's always changing. It's dynamic, and it's going to figure out if you're giving something to the body nonstop. So just kind of think of that 3 month, 6 month cycle. You can always go back on it, but you're at least giving the body a break to where it can produce its own signaling.
Thank you. So, another chat question. In addition to exercise, what have been good muscle sparing methodologies, appropriate protein or peptide co-therapies?
So beyond just exercise, so support exercise?
Uh, in addition to exercise, yeah, what is going to be with GLPs, they clarified.
Yeah, so diet. Again, this is attention to macro and micronutrients. That to me is the biggest problem with GLP-1s and is going to be the end all of GLP-1s is just lack of nutrients. If everybody can get people to use MyFitnessPal while they're on a GLP-1, you're going to have real solid data But the biggest problem with GLP-1s, remember, you have all these personal trainers that we've worked with that have people losing muscle mass, but 50 to 70% of it is lean muscle. This is the worry of long-term GLP-1s is, so yes, we want the muscle mass. The only way you're going to get sustained muscle mass is giving the body the energy needs that it requires. And so yes, it starts with protein, but remember, if you're not giving the body enough fuel, there is a process called gluconeogenesis where it will make glucose regardless of what you're feeding it, and it will start eating up internally or catabolize the body to make sugar. And so with GLP-1s, you want nutrients first. You want to make sure people are getting a bare minimum protein and caloric intake, and then you want to match that person, the individual. Remember, if you have an individual that's on top of it, they're using GLP-1s, they're burning body fat, they're tracking their caloric intake, they're tracking their protein intake, even if they're at a caloric deficit from what they're normally at. Say they're eating 1,500 calories a day and they were eating 2,500 calories a day, but they're eating nutrient dense foods. You can put that person on a secretagogue, a growth hormone peptide. You can put these people on some of these other peptides that can be or testosterone, and get them to be building muscle mass while losing body fat. That's the correct way to do it. So my answer would be is you have to approach everyone individual, and the ones that are doing it right, you can be very aggressive with as far as helping them really do some sort of a physical change. You can see dramatic physical change with people that are doing things right. And that's the ones you get aggressive with other peptides. Otherwise, you're wasting money, you're confusing the situation, you're putting people on products that are likely going to put more of a metabolic demand on them, and you're actually going to potentially sabotage the whole situation and have someone that spent a lot of money and came out feeling really, really poor.
I'm going to go back to a question that was submitted beforehand. So how do you manage nutrient and ingredient inventory for IVs, injections when you're just starting out and the products expire quickly once opened?
That's a great question. So, well, one of the things that we hope is that we are going to have an amazing 503B partner within the next couple months, which is going to help improve on vial sizes, expiration dates, and make this a little bit easier. But in the meantime, when I started out, I picked my favorite IVs, especially one ingredient IVs. I still have a rotation of nutrient IVs that I do. I do a supercharged Myers, which is just a big standard wellness infusion with a lot of ingredients. And then I do a lot of alpha lipoic and a lot of hydrogen peroxide. And these one ingredient IVs make it very easy because this is your rotation that you put the majority of your patients on. That to me is easier for me because I have a lot of my clients that ask for my suggestions on the same rotation, which means I'm going to use these ingredients a lot more often. The other part of it is again, you have to promote. If you're bringing these ingredients in, you have to promote these IVs and you have to promote them aggressively. And like I said, all of them need it. They're all going to feel better on it. It's rare that you give someone an IV that doesn't come back for another one. The other side of it is if you get to a point where you have some of the ingredients that are expiring, all we do is we put them into a different container. We don't sell them, we don't do IVs with them, but we use them internally for ourselves. So that at least cuts some of the losses out where you're still able to use them on staff and yourselves for IVs. And our office does a lot of infusions on ourselves. So that's one at least benefit that sometimes within the 30 to 60 days after they expire, we do move them into an office use bin and then use them on ourselves. But I think that the best thing to do is to start with a couple IVs that you really enjoy, that a lot of your clients like, and then get comfortable prescribing those IVs and then starting to see how your inventory works out. And you just have to be diligent in doing inventory management. But you can get to a point where you got a nice cycle, especially when you get those patients that have bought packages. So you know that they're coming in once a month or once every 2 weeks to get these infusions.
So someone asked in the chat, I'm not real familiar with GLP. I think she meant to say GLPs. Do you have input on this? So Robin, were you asking like the differences between the GLPs?
I had a rep come in and tell me that there is a GLP-3 that she was able to get a hold of herself and was just talking about how it didn't cause you to lose muscle mass, but I'm not familiar with it, and I didn't know if you knew anything about that.
Yeah, so what they're talking about is there's GLP-1s, there's GLP-1s with GIP, and then there's GLP-1s, GIPs with a glucagon receptor agonist. And so kind of how that all works is the new popular one on social media is retatrutide. This is the one that
Yes.
this is the GLP-3, which means it has three modes of activation. And why people really like this is because they all do kind of the same thing with the GLP-1 part of it, which is they're going to slow down peristalsis. They're going to help with appetite suppression. It affects the vagal the communication from the gut to the brain, and so it takes away the food noise. And then the other ones improving insulin sensitivity. But the GLP-3, what they're talking about with retatrutide is that they're saying that retatrutide, although the GLP-1 part of it reduces pancreatic secretion of glucagon, which is minimizing glucose release. But on the periphery, it's actually agonizing or complementing glucagon receptors on the periphery, which increases energy use. So now on the periphery, it's pushing glucose into the cells, but on the inside, it's reducing glucose release. So it's almost like what you would call a really nice scenario just based off of the way this is supposed to work. The problem is that you're hearing a lot of the great things about retatrutide, but you're not also hearing that there's the same side effects that can potentially be there with the other GLP-1s, semaglutide and tirzepatide, which means some of these people just don't have an appetite. So you're still risking, you're still risking muscle loss. It's just not the same because they have this peripheral glucagon management. That's what's making this GLP-3 so much more attractive, especially for those people that are just trying to get rid of a little bit of stubborn body fat while maintaining the gym. And I showed my daughters this. I have daughters that have asked about retatrutide, and what I'm explaining to them is these influencers on social media that are showing how great they look, and they're ripped. And and it's so attractive to think, oh, they got a Retta body. Oh, look at my Retta body. These people are probably, a very safe assumption is that they are making money by influencing these peptides. So they're probably the ones that are calculating their macronutrients. They're calculating their micronutrients. They're taking a microdose. They're doing things exactly right. But they're giving this idea that, you can be obese and then boom, look at your Retabod. It's so just be careful while they're starting to continue to observe these peptides. And again, you can't get caught up thinking that this is a magic pill. We cannot and never will be able to just sideswipe discipline and normal physiology and expect that there's not going to be a consequence at the end. So yes, conceptually, how retatrutide works when you compare them to the other two sounds amazing. And if it 10 years from now, if everyone's doing amazing and all their biomarkers are all great, I'm going to think, wow, that is a true longevity drug. I'm just a little skeptical because they're pushing things out so quickly. So, but do you kind of understand now the difference of the three?
Yes, thank you.
Okay, so yeah,
Thank
so that's why there's all this hype, because it literally is doing something that is very interesting by increasing energy consumption by also controlling insulin sensitivity and resistance. So it's just insulin in general. So it's very novel.
Okay, thank you.
It,
And then a follow-up, another question was about the peroxide, hydrogen peroxide AV. Is it just hydrogen peroxide added by itself?
we do 5 cc's of hydrogen peroxide and 4 cc's of magnesium. We don't always put that much magnesium in it just because some people do get a little tired with the magnesium dosing, but we either put, somewhere between 2 and 4 cc's of magnesium, and it's either 100 or 200
200.
milligrams per ml
It's
of
200
magnesium.
milligrams per ml.
200 milligrams, yeah. So yes, it's a combination of hydrogen peroxide and magnesium, and great infusion. That's one of the gold standard IVs that we've been doing for years and years, and a really good opportunity for those for multiple reasons, but one of them obviously is the antimicrobial component.
So a question you already answered that someone had asked is what peptides need to be cycled, how often, but then they had a follow-up question is how do you document peptide therapies in your EMR?
Well, and hopefully with my practice's new release, the consultation module is going to help organize those types of peptide regimens. Well, they're going to, but right now what we do is because we use a different EHR than we do with our MyPractice prescribing, we just make a note in our chart, so when we say we're going to put someone on 3 months of, 6 months of Cimarelin, we just note that they're going to do a 6 month Cimarelin dosing and then take 3 months off. So we try to keep pretty clear records in our each EHR, and we also put notes of why we're doing it, to improve sleep, just making very good. That's why questionnaires are going to be great, because their questionnaires are, are kind of filling in your subjective data that's going to support your prescribing. And so it's very important to document all of the different symptoms that they're having to also support the peptide regimens. But yeah, you just put them in, your EHR just based off of, what your plan is going to be. So, but that's about as scientific as I can get on that.
So how would be the best way to utilize biologics and peptides to improve patient outcomes in aesthetics and orthopedics?
Yeah, so I know we did the one talk, a webinar on biologics and peptides, and it was a very good response because they're basically working hand in hand. So you can put biologics into the same category as bioregulators, and so it's kind of the same response as the stem cells is working systemically. Any of the biologic products is bringing in the growth factors and the cellular components that are going to stabilize the body and make it in a better situation for the peptides to work. So they really go hand in hand. It's just, again, remember, we just don't have data on biologics. It's not that they don't work. I mean, I have watched stem cells work incredibly from wound healing to erectile dysfunction to just overall health benefits. But we just don't have a lot of data to say exactly what they're doing and how they work without scaring people. So I look at the biologics as the same way as I do all of the bioregulators. It's, when I put people on a longevity plan, stem cells is part of that plan. And usually it's either 1 to 4 times a year that I administer either in an infusion or a localized injection of stem cells or exosomes or a combination of those two. So that's the way I kind of approach them is I know they work, I know what they do internally. So I just work that into a longevity program for those people that want to invest in that and invest a little more heavily than the average person because there is a cost to that. But do I believe that how they work together can create a better long-term solution? Absolutely. There's not much that I've seen that can change someone's health status as aggressively than with some of the biologic products. It's just, you just have to accept them as a bioregulator, understand that you do stem cells, you're not going to walk away and go, oh my gosh, I feel like $1 million. But you know what they're doing internally. And again, they're creating the situation and establishing a homeostasis so that the other therapies you're working on work better.
And Brent, just to clarify too, is we do have a biologics company on our platform if you're interested. We also have the webinar, like Brent was talking about. If you're interested in that, just put biologics webinar in the chat. We'll send that out to you. And I believe Audrey Ward's on here. I know she's hosting a training this weekend, so feel free to chat with her or put your name down and she can reach out to you. But definitely, you've got a great team here of people who understand how to use that.
And then, all right, so we have another question in the chat. So do you recommend addressing hormone modifiers that are found in skincare products and plastics such as water bottles.
Do I address them?
Yeah, do you suggest like I'm assuming she means like with patients, like how
Yeah, we try, but we're constantly that's a whole day discussion. Yeah, I mean, trying to figure out all the different environmental exposures that we're being, that we're faced against, it's almost impossible. That's like um such a disappointment in society is just how much we're trying to navigate just through our daily consumption of normal products. And but yeah, I mean, plastics is supposed to be, again, remember, without some sort of diagnostics or some sort of lab data that can really pinpoint what our plastics level or all we can do is try to be diligent. And again, you're trying to minimize inflammation and maximize our body's response. And so I always come down to energy expenditure. That is what we've seen, especially that was exemplified through COVID, was that we are only as good as the amount of energy that we have stored. At any moment, our energy could be sucked out of us and leave us in a deficit. And if you don't have the metabolic health to support the immune system to do its job at getting rid of some of these toxins and some of these plastics and help the body able to overcome that, you're going to be diseased. And so again, everything that we're talking about in functional medicine is about maximizing our own internal energy production and then adding on anything we can to get us to the point where we are making energy the way our body should be, and we have an energy expenditure that is less than our energy production, our energy manufacturing. And so, when a body has extra oxygen, extra energy, the immune system does what it's supposed to do, and then is going to be in a better position to get rid of a lot of these toxins and a lot of exposures. And so that's why I go back to micronutrients again. We are always in a micronutrient deficiency state. So micronutrient sufficiency, in my mind, is the core of every functional medicine practice because that is a nonstop, consistent, continual replenishment that people will never stop. It doesn't matter how old they are, how young they are. You being able to supply micronutrients to help with the immune response and help with energy production is where everything starts, and then everything kind of fits around it. So I don't see us ever getting the information we need to really understand what we need to do to battle some of these, highly processed foods and some of these plastics that we're getting, off of our cookware, off of our, out of our food. But instead, what we can do is just maximize our internal environment to be able to manage it. And that's the battle that's nonstop, is just energy production and energy expenditure. And if you can win that battle, usually the immune system will do what it's supposed to do. But that's a tough one. I don't think anyone really has a great answer for some of that.
all right. What is the best method or protocol for methylene blue for overall health and wellness? Oral, injection?
Yeah, well, that's another tough one because remember, methylene blue just came out of the woodwork there, and everybody wanted to be on methylene blue. And this is something that's been around for, I think, around 100 years, and it's been used for various things. But most importantly, everyone's interest is in the mitochondrial cycle. Is basically what can methylene blue to mitochondria uh, um, overall mitochondrial function. And again, remember, methylene blue has a way of potentiating the mitochondria to make energy without some of the necessary ingredients or fuel, meaning NAD or our salvage pathway, is that methylene blue has a way to keep the mitochondria firing when we're in a deficit. And can that do that forever? Absolutely not. And so again, people that are taking methylene blue for the mitochondrial component, which is really what we're doing it for, because otherwise it's for methylhemoglobinemia or from antimicrobials. And when the dosing initially came out, this was a lot of influencing on social media. Everyone was talking somewhere between 15 and 50 milligrams of methylene blue. That is dosing that is very confusing when you're looking at the 1 to 2 grams per kilogram IV that they're doing. But for oral dosing for mitochondrial enhancement, the dosing is much less. I mean, some doctors are saying between 1 and 5 milligrams. but we have a lot of patients on 15 to 25 milligrams, which I think is doing what we talked about earlier, was if you just keep firing methylene blue and trying to get the mitochondria to bypass its normal function, you're going to get a burnout phase. And that's why I think some people start to feeling tired, feeling a little bit dysthymic. And it's because you're just peppering the body with a substance that at a dose that wasn't ideal for the job that you're trying to get it to do. So hopefully you're going to see some integrational functional medicine doctors that are coming out and actually promoting lower doses of methylene blue. But low dose methylene blue, while people are trying to titrate off of GLP-1s along with NAD, you've heard me talk about that combination. I think it's great, but I just think you're going to need somewhere more between that 5 and 15 milligrams, if not lower, for the mitochondrial support, and not, again, overdoing it just because, and not having some sort of a cyclic approach to it. So if you're going to use methylene blue, use it for 3 to 6 months and then take a 2 to 3 month break. And again, just make sure you're staying up on some of the dosing regimens, because the people that are buying it offline are just dosing it based off of what influencers are telling them, and they don't have any medical background or are not looking at the data.
And then a follow up with that is, do you recommend or do you like recommending near infrared sauna with methylene blue?
I don't. I love infrared saunas. I don't know a direct combination. I don't know the direct correlation between using methylene blue with infrared. I'm sure it's good, but I don't know if infrared, activates methylene blue or something, being a dye. I don't know that.
So we only have about 7 minutes left. There's a couple questions, unless anyone on here wants to unmute and ask anything specific. Or you can ask, it said near infrared and MB are synergistic. So
Oh, nice.
So we had another question asked. Someone said, I'm having difficult time getting CJC to my patients. Is there an alternative that I can use? What would dosing be for that item? This is someone that is not on our platform. We do have CJC from several compounding pharmacies available on the MPC platform. But
So yeah,
if
and if you're
someone's
not,
not,
yeah, so you can obviously, get it from these sources. Casey can help you with that. But I still like good old, CJC and ipamorelin is a GHR, growth hormone releasing hormone, and a growth hormone releasing peptide combined. You don't have to use that combination. You could always use just a growth hormone releasing hormone like Sermorelin, which has been around for years, still works great. But just remember, you're not, you have to try to find out why these people want these peptides. They're going on social media, they're hearing these people talking about them. But remember, you want to guide your patients correctly. You want to make sure you understand why they want to be on it, so that one, it's good education for yourself to kind of use that as your conservative approach to functional medicine, meaning you don't have to put everybody on anything. So I would start, do they really need CJC and ipamorelin? What are they using it for? And are you going to be tracking their successes? What are you looking for to look at in 3 to 6 months with them being on it? And if you can't get it, then I would look at Sermorelin. Tesamorelin is another one out there. It's another GHRH, but it's a little bit more expensive. And that one the research on that one was all based off of HIV and AIDS patients, and did show that it did support lean muscle mass and lipolysis better than some of the other growth hormone releasing hormones. But overall, you could use any of those in that category. You don't have to have a growth hormone releasing peptide attached to it. So Sermorelin is an easy one. You can go up to 300 micrograms, if not higher on that dose, especially if you know exactly what result you're trying to get out of it.
So then we have Precious. She said, I have an APRN operating a physician supervised aesthetic and hormone optimization practice in Georgia. I am evaluating the integration of peptide therapies into our existing hormone and metabolic programs from a compliance and documentation standpoint. Which peptides are considered most defensible in a clinical practice, such as Sermorelin, CJC, ipamorelin, BPC 157? Do you want me to keep going, or do you want to answer that?
Well, you're going to see that, it's very easy to see which ones are on the green list. Those are the most defensible. But remember, my belief is if you document a need and you have a solution, a functional solution, um, it's rarely that the providers are going to get nailed. If you're doing a great job, now if you're a peptide machine, you just have every single person on 5 different peptides. You're on the Wolverine blend, the Clo blend. You're just dishing out peptides. You're going to be a little bit more under the microscope. But if you're doing good functional medicine, meaning that there's a reason why you're putting these people on it, and here's the host of symptoms they have. This is what you're using the peptide for. You're not going to have any problems. It's defensible. These are available. Pharmacies are making them, and you're just trying to be a good provider, utilizing them. So the ones that are obviously going to be the safest are the green ones. The Samoralin, even human growth hormone, is still being utilized. But once you start getting into some of these anti-inflammatory peptides or the boutique peptides that are used a little bit less, but are under the microscope, your risk is there. But again, I've explained to people that I will not stop using certain peptides on patients that have a functional need for them. So I just document, I put them on them. If someone comes and tells me I got to stop, then I will stop. But if I have patients that are doing well on them and have been doing well on them and have a functional use for that peptide, then I just document and I'm going to continue to use them.
And then she wanted to know specifically what documentation structure best supports medical necessity. I'm guessing, like, I know you had mentioned earlier, you always put symptoms, correct?
Yeah. Yeah, just
And
make a template, make a template for most of these people because most of them are going to have clinical need. Their age is one of them. So anybody that's aging over the age of 45, they already know that the number of most hormones are declining, and then anybody has any chronic disease, anyone that's on any medications, anybody that has any complaint, whether it be joint pain, brain fog, insomnia, a loss of lean muscle mass, extra body fat. All of these warrant most of the peptides, at least in some cyclic usage.
and then the last part was how are providers appropriately stacking peptides alongside hormone replacement therapy while remaining in regulatory compliance?
Regulatory compliance is out the door in functional medicine. What they're trying to tell you to do is practice traditional medicine. So when they look at what we're doing on a regulatory side, there's no medical input on what we're doing in being. So when you look at the regulatory landscape, we've been practicing in the gray area from day one, and we're never going to stop. I mean, insurance doesn't cover anything we do. They don't research or cover any of the products that we're prescribing. So we're really looking at, again, what is the best medicine? And yes, we have to be a little like that's like retatrutide. Retatrutide seems pretty darn interesting, but yet the FDA has made a bold statement saying that we are not tolerating people using retatrutide when it's an investigational drug in actual trials right now. So am I prescribing retatrutide? No, I'm not. Am I using the other ones? Yes, I am. So if you're trying to really look at the regulatory landscape, try to stay clear of the ones that the government's making a strong statement against and use some of the other ones. But overall, if you're not doing this herding cattle or just prescribing everybody anything that they want without without reason, you're going to put yourself in not only just under the microscope, but that's not good medicine. So just think about when you're doing your practice, do it well, document, actually practice functional medicine, which means you are trying to get the best result for your clients individually, which all of them are going to be different. And if you're doing that, you're getting great results, you're documenting your care, you're not going to get into trouble. This has been going on for 25 years, 30 years now. It's just, I don't see the good practices getting into trouble. It's the ones that are doing telehealth or doing a lot of aggressive dosing and way too many people on peptides, and it just almost looks sloppy. So if you don't do that, you're not going to have any problems.
Awesome. Thank you so much, Brent. I think that's time, and I think we got basically all the questions answered. But thank you to everyone that came. We really appreciate you joining us today. And I believe we'll do this again in 2 months. So not next month, March, but we'll do it again in April.
Yeah, and
So
Casey,
please.
I mean, if this is something that people like this format, this is an easy one. This is, we're all eating lunch. This is some, we don't have to wait 2 months. If this is something that's helpful for you guys, especially that you can get some of these questions answered that are going to really affect your businesses, so that you guys can move forward, and especially business growth or business development. We can do this again earlier. So just let Casey and Shelly know if this is something that was helpful, because this is easy for me. This is an easy conversation to just, provide knowledge through my experiences to hopefully help you guys make good decisions going forward.
If you have other questions or just, you know, patient specific, or like Dr. Agin said, practice, procedure, policies in place, just send them over, and you can send it to me. You can send it to Casey, CASEY at MyPracticeConnect.com, or you can just do info@MyPracticeConnect.com. Thank you everyone for coming. We really appreciate it. Dr. Agin,
Thank
thank
y'all.
you. You are amazing.
Thank you. Thank you.